we're going to go ahead and kick things off with our first session of UO1s. And this session is going to be looking at modeling COVID prevalence, transmission, and mortality. And we've got three great speakers lined up for you. And the first person we have for you is Dr. Yajuan Si at the University of Michigan. And she's going to be talking about her project, Understanding Social Determinants of Health Disparities and COVID-19 Transmission. So with that, I'll turn things over to you.
Thank you, John. Thank you, everybody, for being here. My talk is a nice connection or follow-up to Ryan's presentation. So, about social determinants of health disparity. So for this talk, I will focus on COVID-19 transmission, but for our UO1 project, we also cover the same issues for immunization. So we want to look at whether it is vaccination introduced or naturally acquired or infected immunization. So hopefully we can have more conversations with DHHS to apply the tool I'm going to introduce. This is our team. We have a terrific group of physicians, software engineering researchers. John Zener is also part of the team as an epidemiologist, and Catherine and Tuan, both of them are here, and they have done most of the work. So we have 4 aims for the UO1. The work we present today cover the first 3 aims. We want to estimate the virus infection incidence and immunity prevalence in the community. So the community could be the population overall level or the subgroup specific definition. So for the subgroup, we focus on both demographic and the geographic subgroups. And for the aim 2, we look at health disparities with respect to COVID symptoms. So we look at individuals who are COVID asymptomatic versus those who have COVID symptoms. Then we try to study the social pathways for these health disparities and also how these disparities or differences may interactively impact the social demographically dependent spread of the disease. So aim 2 is an extension from aim 1 about first estimating the prevalence. Then we try to contrast the prevalence in terms of COVID symptoms. And then for aim 3, we try to make our approach publicly available. So we focus on a method. If you guys have heard me for the previous annual meetings, Mr. P, multi-level regression and post-stratification, we make this Mr. P interface publicly available so that general researchers without sophisticated statistical knowledge can apply our approach. And then aim 4 is the most exciting and ambitious aim. So we want to do data harmonization. As I move on, you can see that we use electronic health records from the hospital, and we would like to integrate the HR data with other COVID-related data collection, especially surveys in this building. So we want to think about the harmonization in terms of measures and sample representation between EHR data and survey data collection. So the overall goal is population representation with a reliable contrast in terms of the measures. So the background about the data source. Through COVID, there's no probability-based survey data collection about either the infection or the immunity. So we have used a synthetic randomized approach to estimating the underlying COVID infection trend. So our idea is based on the patients who have surgery appointments with the hospital, and they are required to take the COVID test. And they have to be COVID asymptomatic. So the underlying assumption is that they get their COVID test because of the surgery requirements rather than their underlying COVID outcomes. So that's why we call this as a synthetic randomization approach. And this approach has a few strong but reasonable assumptions. So we look at COVID asymptomatic patients, and we assume that within a uniform demographic distribution. So for example, if you look at female 65-year-old white, we assume there is a constant ratio between asymptomatic and symptomatic patients. So if we follow this strong assumption, we can track the true prevalence through the asymptomatic patients, assuming you can just inflate the magnitude by the constant to achieve the overall prevalence. And then for COVID infection, the asymptomatic patient's detection would be a few days earlier than the symptom. So this would give us a time window to predict the potential clinical burden. So these assumptions are the root of our approach in terms of the synthetic randomization. But from the survey or statistical methodology perspective, we assume that given the adjustment of your sociodemographics, there is independence of your COVID test tendency or selection into our data set with your COVID potential outcomes. So we are essentially accounting for the selection bias of the electronic health records by adjusting for the sociodemographics. And the adjustment approach, like I said, is the well-known Mr. P. Mr. P was used for election forecasting, mainly because of the differential net response in the pool or survey data set. So we apply the same idea to adjust for sociodemographics in the EHR data. But then how would you get the target population you want to match to based on the EHR data? So for the COVID test, we gather the patient's age, sex, race, and their 5-digit zip code. So we use their zip code to link to the American Community Survey. So there will be some approximation between the zip code to census tract linking, because it's not a nested structure. But we assume that the residence or the information we get from the ACS data represents the target population these hospital patients represent based on this geographic linking. So the residents living in the catchment areas defined by the list of zip codes we get from the HR is our target population. And then we use that linking process to achieve two goals. First, if we have defined our target population, we can get the population demographic distributions based on the ACS data. That's the goal for the P step, the post-stratification step of Mr. P. So we'll adjust for the selection bias due to sociodemographic discrepancy. And the second goal is to obtain the zip code level predictors. So we assume that in addition to the individual sociodemographics or demographics, your neighborhood level characteristics could potentially affect the COVID infection too. So we use the ACS individual records, then aggregate them to the zip code level to create a neighborhood or community level measure. And these measures include poverty, income, employment rate, and we use another summary of neighborhood deprivation. It's called the Area Deprivation Index, ADI, and then we are also contrasting this with the NANDA measures. And here, this shows the whole linking process. Essentially, we start from the EHR data, then we link to the ACS to obtain the population records, and then we run the Mr. P interface. So we have developed this interface. You can upload your data. We have two panels, the spatial temporal data. We are referring the kids with the COVID test because we have your zip codes, we collect those tests across time. But we can also analyze the cross-sectional data set if you ignore the time varying component. And I will briefly talk about some key results from our current work. So here, this is a Michigan map, and we use the Michigan Medicine electronic health records. From the left side, if you just look at the raw positivity, it doesn't make any sense because the values change between 0 and 1, and you have 1 in one county, but zeros in most of the cases. That's where the MR, the Mr. P step plays the role. So we build a multi-level regression model to smooth the estimates based on their sociodemographics and the zip code level predictors. So the estimated prevalence would vary between 0 and 7%. Here, it is essentially a small area estimation trick, but will adjust the representation of sociodemographics. And then for the health disparity research, we were looking at the asymptomatic and the symptomatic prevalence. So we look at the state of Indiana and Michigan. So if you are infected, we observe that non-white tend to be asymptomatic comparing to white. So biologically, this is not making sense. That's where we are trying to study the social determinants. And this is also related to the health communication we have been talking about in the previous session. How would we interpret this, and then how to communicate this disparity to the public? This is a challenging problem we currently trying to address. But the data do show that for different racial groups and age groups, here I only present the race result, we do see different ratios across these demographic groups. And if you want to learn more details about the 2K results I just showed, my student and research associate will present a poster tonight, and you can see the details in terms of the health disparity investigation and the Mr. P interface. So we are currently moving to the aim4 to integrate multiple data sources, and that's where we will collaborate closely with John and Megan from the Consortia Coordination Center, try to integrate EHR with different survey data, and also try to integrate the individual records we have with the community level or geographic level summaries you guys have deposited so far. And like I mentioned, we will move the investigation from infection to immunization, because we believe, or we hypothesize, that there is a huge underestimation of immunization. If you only look at the vaccination records, that's not enough. And then we also try to think carefully about the privacy protection with the HR data, especially with the 5-digit zip codes. How would we protect the HIPAA complaints related confidentiality? So we have a few references related to this presentation, and I'm happy to talk more with you guys. Thank you.